Imagine you're running a really vital public health campaign. Let's say screening for high blood pressure in your local area.
Classic scenario.
Exactly. So you launch the service, standard 9 to 5 clinics, everything's set up. But then the data comes back and you see this dilemma. The people in the most deprived areas, the ones we now know as the Core 20 groups,
Right.
they're not showing up.
The very people most at risk.
Right. Uptake is critically low, the health gap is actually getting wider, and it's happening on your watch. You have a legal duty to fix this. So, what is the specific NHS playbook you are required to follow?
And that scenario, it's the day-to-day reality of health inequalities in the UK. Today, we are diving deep into the answer to that question, which is the Core20PLUS5 framework.
Okay.
This is the official national NHS strategy. It's designed specifically to address and narrow these systemic gaps. It gives us a really clear structure on how to not just offer services, but how to properly target them, tailor them, and then track them.
So we've synthesized a set of expert notes that really treat this framework as a critical guide for decision-making, especially if you're preparing for high-stakes assessments or you just want to make sure your practice is ethically sound.
And legally compliant.
Absolutely. So this deep dive is essential. We're going to unpack the three components, look at the legal duties, and most importantly, reveal the high-yield actions that actually deliver equitable care.
Let's do it.
So where do we start?
Well, let's start by defining the actual problem this framework is built to solve. Health inequalities. The official definition is unfair, avoidable differences in health and healthcare between groups.
And the key words there are unfair and avoidable.
Exactly. They're not just random variations. They're systemic issues that need a proactive and really targeted intervention.
And this isn't just a sort of policy recommendation, is that there's real legal weight behind this.
Oh, absolutely. This is where it gets really interesting, especially from a governance perspective. NHS bodies, so we're talking about integrated care boards, ICBs, and trust.
The big play.
They have explicit, non-negotiable legal duties. They have to meet these expectations around equality and reducing health inequalities in all their planning and their service delivery. And this framework, Core20PLUS5, is basically the system they use to prove they're meeting that duty.
So it's their roadmap.
It is. And if you want to boil it all down, the central truth, the one-sentence takeaway for you, especially for revision, is what we call the T3 model.
T3.
Target priority groups, tailor access and support, then track uptake and outcomes visibly. That structure, target, tailor, track, turns vague good intentions into something measurable and mandated.
Okay, let's unpack that structure then. The name itself, Core20PLUS5. Let's start with the biggest piece. The Core 20, what does that mean in practical terms?
The Core 20 refers to the most deprived national quintile. So the 20% of the population identified using the Index of Multiple Deprivation, the IMD.
And the IMD, just to be clear, that's a geographical measure.
Yes, exactly. It's based on postcode. It looks at different domains like income, employment, health, and it gives you a score for that neighborhood. The whole point of focusing on the Core 20 is to concentrate our resources where we know the health gaps are the most severe.
Right, so it stops you from spreading your efforts too thinly. You focus on that 20% where the need is demonstrably highest. But that's about geography. What about the PLUS?
The PLUS is where local customization comes in. These are groups that are defined locally. They're identified as having worse access, maybe worse patient experience, or worse outcomes, regardless of where they live.
So this could be different from one city to the next.
Precisely. The sources mention inclusion health groups as a key example. So people experiencing homelessness, sex workers, maybe specific ethnic minority groups facing very particular barriers in that area, or people with learning disabilities. The PLUS makes the framework flexible.
Okay, that makes sense. Then we get to the really specific part, the 5. The 5 clinical priorities. Why these 5?
They were chosen because targeted intervention in these areas offers the biggest potential impact on closing those common avoidable gaps.
Can you run us through them for adults?
Of course. For adults, the 5 pillars are, number 1, maternity care. 2, physical health checks for people with severe mental illness or SMI.
Okay.
3, chronic respiratory disease management. 4, early cancer diagnosis. And 5, hypertension case finding.
Let's just pause on number 2 for a second. The SMI physical health checks. Why is that one so critical that it's a national priority?
I mean, the health inequality gap there is just catastrophic. People with severe mental illness because of all these systemic barriers often have a life expectancy that's 15 to 20 years shorter than the general population.
15 to 20 years.
It's a shocking statistic.
Yeah.
And the vast majority of that difference is driven by avoidable physical health conditions,
Okay.
things like cardiovascular disease or respiratory problems. So that's why proactive screening is one of the 5. It's a direct response to that life expectancy gap.
Wow, that really puts it into context. It's about real, measurable impact. And we should probably just quickly note there is a separate version for children and young people, right?
Yes, there is. The CYP version has adapted priorities. It focuses on things like asthma, diabetes, epilepsy, oral health, and of course, mental health access for young people.
Right. So now we know the who and the what. Let's get into the how. If we're trying to follow our T3 duties to target, tailor, and track, what are the specific high-yield actions we need to be taking?
Okay, so you have to start with data. You ground everything in data. The first high-yield action, under targeting, is to proactively identify your core 20 postcodes and your local PLUS groups.
So you know who you're aiming for.
And then you systematically stratify your existing data, so your waiting lists, your referral rates, your outcome metrics, by those categories. You have to prove the gaps exist with IMD or ethnicity data before you even start to intervene.
And once we have that data, we move to tailoring the service. This is the barrier-busting part, I assume.
This is where the real work happens, yes.
Yeah. So if we go back to our hypertension screening scenario, what are the non-negotiable adjustments we have to make?
The sources are really clear on this. It's about practical adjustments that dismantle the classic barriers. First one, flexible slots. If you only offer 9 to 5 appointments, you are actively excluding huge groups of people.
People in low-paid, inflexible jobs.
Exactly, who are heavily concentrated in core 20 areas. So you have to offer evening, weekend, or even just drop-in appointments.
I see the logic there, but I have to ask, if we offer flexible evening slots, doesn't that just risk burning out the existing clinical staff? How does the framework balance that?
That's the key operational challenge. And it's why successful implementation isn't about just adding more work. It requires a redesign of the service.
A systems change.
Yes.
Yes.
This often means moving staff out of the hospital and changing the venue completely, taking clinics to community centers to places of worship to hubs that people already know and trust.
You go to them.
You go to them, it reduces travel time, cost, and a lot of the psychological barriers associated with big, intimidating hospitals.
And access isn't just about location, is it? It's about communication. You mentioned interpreters and something called the Accessible Information Standard, the AIS.
That is absolutely critical. And the AIS is a legal requirement. It's about making sure patients can actually communicate and understand information about their care. This isn't just about language interpreters.
Right.
It's ensuring patients with learning disabilities get information in easy-read formats, or providing British Sign Language interpreters for deaf patients. And then there's the huge one, digital exclusion.
The online-only trap.
Yes. Any push for efficiency by making booking online only is basically an act of exclusion for many marginalized groups. You must always maintain non-digital routes, phone lines, walk-in options, face-to-face registration, always.
So that makes the best practice model pretty clear. Something like, let's run an evening walk-in clinic, off-site at the community center, with interpreters and non-digital registration.
That's a perfect high-scoring phrase. And the final key to tailoring, the bit that separates good from great, is co-design.
Working with the community itself.
You have to. Working with community connectors, with the VCSE sector, that's voluntary, community, and social enterprise groups. They hold the trust that the NHS sometimes struggles to build. It ensures the service isn't just a top-down mandate.
Okay, so we've targeted with data, we've tailored by removing barriers. Now we have to prove it all worked. That brings us to the final T, tracking.
Tracking is non-negotiable. Action 3 is measuring your uptake, your patient experience, and your clinical outcomes, specifically by deprivation quintile, by ethnicity, and by your PLUS categories.
Because if you don't measure the difference, you can't prove you've made a difference.
Exactly. You can't fix what you don't measure. And this rigorous tracking allows you to, as the sources say, tweak iteratively. You learn from the real-time data, you adjust the service, and you relaunch a better version quickly.
Okay, let's shift gears a bit and talk about the pitfalls. For anyone making these decisions, what are the trap answers? The options that might sound reasonable but actually make the health gaps worse.
The logic here, especially from an exam point of view, is absolute. You get points for targeted, proactive intervention. You lose points for generic inaction.
So what's the #1 trap?
Trap number 1 is the generic, passive approach. We'll put up a general poster on the practice notice board and hope people come in.
Which we know they won't.
It's completely untargeted. It fails to address any of the known barriers, and it just assumes a universal offer is an equitable one. It guarantees the gap will persist.
And the digital trap we touched on.
Trap 2, ignoring digital exclusion. Any option that says online-only booking for administrative efficiency is an immediate failure of equity. You must always have those non-digital alternatives.
I want to ask about an ethical trap here. If we start stratifying waiting lists based on IMD data to target core 20 groups first, how do we ethically manage the perception that we're, prioritizing some patients over others?
That is a critical question. But the ethical mandate from the NHS and the GMC is clear. The duty to reduce health inequalities actually supersedes the duty to treat everyone identically.
So equity over equality.
Precisely. Equity requires differential treatment to achieve equal outcomes. If your data shows a 20% uptake gap in your most deprived communities, then proactively targeting those communities isn't favoritism, it is mandatory corrective action under your legal duty.
That clarifies the mindset you need. What about data collection itself as a trap?
Trap 3, lack of data. Choosing an option like collect no IMD or ethnicity data to avoid burden is a fundamental failure. You're essentially choosing to be blind. You can't track the gap, you can't demonstrate improvement. It completely undermines the entire framework.
And the final one, the temptation to just wait.
Trap 4, delay. Options that sound like wait for the ICB to allocate funding next year, or let's get through winter pressures first. Equity work is always urgent. If a barrier exists now, action has to start now, even if it's just a small pilot.
So the message is clear. Any action that is targeted, practical, and measured will always score highest over something generic, passive, or delayed.
Always.
Okay, let's wrap this up. Can you give us a quick recap of the 3 most essential takeaways from this deep dive?
Of course. First, use Core20PLUS5 to focus your action, specifically on the Core 20 most deprived areas and on your locally defined PLUS groups.
Target.
Second, remove the practical barriers.
Yep.
You do this by using flexible offers, community venues, providing interpreters, and crucially, ensuring non-digital access.
Tailor.
And finally, track your impact visibly. Measure everything by deprivation and ethnicity and be ready to iterate and improve based on what that data tells you.
Track. It really shows that equitable practice isn't about treating everyone the same. It's about providing targeted, tailored support to achieve fair outcomes. The real challenge for you as a clinician or a leader is to make sure that barrier busting is built into every service you design right from the start.
Absolutely. That is the difference between just having good intentions and having a demonstrable impact. And understanding these structured systems like Core20PLUS5 is essential for effective UK practice. For anyone preparing for crucial exams like the MSRA, grounding your learning in these system-based, ethically mandated approaches can really transform your decision-making.
And for more on that, I believe you have a resource.
Yes, for more targeted learning and revision strategies around these kinds of topics, you can explore resources like passtheminsurate.com.
Thank you for joining us for this deep dive. Now you're informed.